Good evening, everyone, and welcome to tonight's MSK Ultrasound virtual workshop organized by Canon Medical Systems in conjunction with SGCR Wires 2022. I'm Meng from Singapore General Hospital, and I'll be your moderator for this session. Musculoskeletal ultrasound has come a long way from the 1990s when I qualified as a young radiologist. At that time, MRI was the big thing in MSK imaging. So when I was due for fellowship training, it was perhaps fortuitous that there was no training position for musculoskeletal radiology, which was what I was interested in. And the only training position was available in ultrasound. I therefore embarked on a fellowship to learn musculoskeletal ultrasound, an area of radiology which was hitherto non-existent in Singapore. Over the years, improvements in ultrasound technology, the area has grown by leaps and bounds, and today ultrasound is an established MSK imaging modality. So I'm very pleased to start today's session. Firstly, just to let you know, we'll be going through a series of pre-recorded talks, and at the end of it, there'll be a session of Q&A for 15 minutes. And so please view your questions in the Q&A chat box, and we'll try to address them at the end of the session. And it now gives me great pleasure to introduce the first speaker, Mr. Stephen Bird, who will be talking about ankle inversion injuries. Mr. Bird is a general sonographer from Adelaide, Australia, and he has vast experience with 30 years of clinical background. He holds a general and vascular DMU and a Master's of Medical Sonography from the University of South Australia. He's a passionate educator, and I can lay witness to this, and I've seen him teaching before. He regularly teaches in national and international conferences and conducts workshops for diagnostic medical ultrasound professionals. And his educational resources have been kindly shared with everyone, and you can look at this URL. And let me now welcome Mr. Stephen Bird.
Welcome to this presentation on ankle inversion injury assessment. This is what my typical patient presents to me looking like. They'll have some swelling over the lateral side of the ankle, and they'll often have some swelling and bruising on the posteromedial corner of the ankle as well. The swelling here is usually from an anterior talofibular ligament injury, calcaneofibular ligament injury, and if I see just swelling with no significant bruising, I think that it's just going to be a simple ligamentous injury, and the swelling is really from the synovial fluid from the ankle joint that's leaked out into the subcutaneous space. When I see significant bruising, then I also think there needs to be a more complicated injury, and at least an avulsion fracture, so at least a little piece of the talus that's been pulled off with the ATFL, maybe a anterior tubercle of the calcaneum fracture, maybe a base of fifth fracture, etc. And the bruising and swelling on the medial side is because of a contra-coup collision injury where the medial malleolus of the tibia collides with the talus, and this results in the so-called posteromedial impingement or POMI lesion. It's important to remember that the ankle has two articulations. The articulation I'm moving now is the ankle joint, so that's the blue one. And the side-to-side movement I'm doing now is the subtalar joint, and that's the green one. So a little bit like the wrist, we need to consider two articulations. We need to assess both of these joints independently, as one may be pathological and the other one normal. And so we need to consider them independently. So this is the anterior ankle joint, and the top left-hand picture shows a normal joint. This one here in the top right shows an effusion, and the bottom two show a bloody effusion. So this is a hemarthrosis. So the bottom two videos really indicate there's been a significant fracture, maybe of the talus, and these people will need cross-sectional imaging. The subtalar joint sits between the talus and the calcaneum, so it's this joint here, and then this area here, which you can see on the MRI is a sort of fatty signal here, this area here is the sinus tarsi, so the posterior subtalar joint can express fluid posteriorly here, but also anterolaterally here into the sinus tarsi. So the trick to finding the subtalar joint is to come down the peroneal tendons in short axis. When you arrive at the CFL, the calcaneofibular ligament, look anterior to the peroneal tendons, and you'll see a crack in the bone, and that is the articulation between this bone, the calcaneum, and this bone, the talus. If you keep sliding down this way, you'll lose the talus, you'll keep the calcaneum, and you drop into this triangular fatty area called the sinus tarsi. So we're coming down the peroneal tendons here in transverse, and we're just arriving at the CFL. There's the calcaneofibular ligament. Then next we'll see an articulation. There's the articulation there. So this is the calcaneum, this is the talus, and now we continue down the peroneal tendons. You drop into the sinus tarsi, and you can see that nice effusion there, and that effusion belongs to the posterior subtalar joint. In this case, we're just doing the same trick, and you can see exactly the same anatomy. However, when we drop into the sinus tarsi, in this case, you can see that it's not just a simple effusion, but it's actually a hemarthrosis. So this makes us very suspicious that there's going to be a talar fracture, or in fact a calcaneal fracture. This is a little bit different. In this case, when we drop into the sinus tarsi, we see a multiloculated, non-compressible cystic area, and this is a ganglion. So my simple rules are that if the fluid is in this corner here, so in the lateral component of the sinus tarsi, and it is monoloculated and compressible, this is a subtalar joint effusion. And if the fluid is in any different location and it is multiloculated and non-compressible, then this is going to be a ganglion. The next ligament we have a look at is the anterior talofibular ligament, which runs between, as the name would suggest, the fibula and the talus. It's a beautiful, strong piece of collagen, and it is just part of the joint capsule. If you look at these diagrams, they're a little bit misleading because it looks like it stands here all alone, but in fact, it's all just part of the ankle joint capsule. So when you tear your ATFL, you will leak fluid from your ankle joint into the subcutaneous space. How I find the ATFL sonographically is I run my finger up underneath that lateral malleolus there, and when I run it underneath the lateral malleolus, I then place the transducer on top of my finger. So you can see what I'm doing here. You'll notice I've got the ankle in an inverted position, and this lines me up perfectly on the anterior talofibular ligament and makes it very, very easy to see. The other trick with the transducer positioning is to make sure that you're up on the fibula and your transducer is parallel to the sole of the foot. So inverted, parallel to the sole of the foot, up on the fibula, sitting on top of your thumb there. This is what it looks like just using transducer pressure to see an ATFL that's ruptured, and you can see the way that it's really soggy and mushy, and that the two ends of the ligament are no longer attached to each other. So this is a typical ATFL rupture, and this is a typical ATFL rupture where it's taken a significant avulsion off of the talar end. So in the previous one, I'd expect to see a lot of swelling. In this case, I'd expect to see more bruising because that little avulsion off of the talus is going to bleed quite significantly and add to the bruising component. Here's another one where we've got a significant little avulsion off of the talar end, and also underneath the ligament. You can see this avulsion has not just bled into the subcutaneous tissues, but it's also bled into the joint, giving us a hemarthrosis. Constance Serlin, a wonderful sonographer from Melbourne and a great mentor of mine, has come up with this really creative idea where you modify the old-fashioned anterior draw test into an ultrasound test. So we lay the patient prone on the couch, and with the foot hanging off the end, you put the transducer lined up perfectly with the ATFL in that location, and then you put downward pressure on the calcaneum. And what that does is it pushes the talus anteriorly, and it will tension the ATFL. It's called the Quanson modified anterior draw test, and it works really well. So this is an example of a normal ATFL. You can see the way that as we're pushing down, it's just taking the strain. There is absolutely no movement of the talus away from the fibula there, and this is a normal anterior talofibular ligament. This, however, is examples of anterior talofibular ligaments that have been partially torn, and you can see the way that the talus becomes hypermobile. It moves away from the fibula, and you can see the crack opening up inside the ATFL when we put it under stress. And in this case, you can see the way that this is really a complete rupture. And you can see there's a complete Suez Canal running through the middle of this anterior talofibular ligament. Again, notice in this case that it's a rupture through the middle of the ligament. There's no avulsion fracture. I would expect this patient to have lots of swelling, but not necessarily too much bruising. And these are more examples of the anterior draw test, the Quanson modified version, working really beautifully to show what looks like a slightly heterogeneous anterior talofibular ligament until you put the stress on it, and then you can see the way that it just cracks open, and you can see the way that it is a high-grade injury of the ATFL. And in this case, you can see that the little avulsion fracture, which is mobile, you can see I'm just wobbling there as I'm putting the downward pressure on there because it's quite a strong force being applied, and you can see the piece of fibula, the avulsion fracture, moving relative to the rest of the fibula. This is what it looks like if you scan one of these patients a few weeks after their injury, and you can see the way the anterior talofibular ligament doesn't have any collagen structure anymore. So it doesn't have linear lines. It looks like a particle board type of appearance, and this is because this is granulation tissue. So this is scar tissue. It has reconstituted successfully that part of the joint capsule and has prevented any further leakage of synovial fluid into the subcutaneous space. And you can see underneath the ATFL there, the reconstituted one, you can see the fluid in the joint there between the fibula and the talus. You'll also note that the talus still moves a little bit more than it should, so it's not completely stabilised yet. This needs some physiotherapy and proprioceptor exercises, etc., to complete the rehab. The next ligament is the calcaneofibular ligament, and it's technically challenging because it sits underneath the peroneal tendons. To see this ligament successfully, you need inversion and dorsiflexion concurrently. But I've got a new method now which I think works really well. So what I do now is I actually put the patient prone, and it works really nicely. I'm going to have them prone for the Quanson modified anterior draw test. So when they're prone, I then look at the CFL with a bit of inversion dorsiflexion, and it's just the gravity effect that pulls the talus and the calcaneum this way a little bit, due to gravity when they're prone, and that tightens up this ligament really beautifully. When you try this when you get back to work, you're going to find it works really, really effectively. And then what I like to do is a short axis assessment of the CFL, and that really allows me to show this fibular end really nicely with a minimum of anisotropy problem, because you can rock the transducer through this lateral gutter of the ankle and really compensate for your anisotropy really effectively. So have a go at the prone position. You'll get really beautiful pictures. So this patient's prone, and I'm just now putting them into gentle dorsiflexion and plantar flexion. You can see how beautifully you can see the fibular end of that CFL, and you can see the way that it trampolines those peroneal tendons on top of it. If you look, there's a little bit of fluid always underneath the calcaneofibular ligament, and this fluid underneath is in the subtalar joint. So this is the articulation between the talus here on this side and the calcaneum on that side. When you rupture your CFL, you'll get a communication between the subtalar joint and the peroneal tendon sheaths, and you get fluid moving into the peroneal tendon sheaths. So this is an example of a calcaneofibular ligament rupture, and you can see how the calcaneal end is really fat and hypoechoic, and then the fibular end is completely disrupted here. So this is a classic CFL rupture. If you can see that the calcaneal end is beautiful and tight and fibrillar and echogenic, then the fibular end, even if it's technically difficult, will be intact. When it tears away from the fibular end, which is the end it always fails from, then you'll see the calcaneal end become fat and hypoechoic and retracted, just like this example. Here's an example of a CFL that's completely torn, and you can see now this beautiful communication between the subtalar joint here and the peroneal tendon sheaths. So the fluid in the subtalar joint now flows into the peroneal tendon sheaths. So next time you see a peroneal tendon sheath full of fluid, just consider the concept of a CFL rupture. I also consider the ATFL and the CFL to form part of a continuum. So the anterior talofibular ligament, which is here, and the calcaneofibular ligament that's here, you can see on this diagram how they almost match up. Whereas when you look at a cadaver, they really do match up. And so what happens is when you tear your ATFL from the fibula and your CFL from the fibula as well, you deglove this piece of tissue sitting across the top. So you can see here the CFL is retracted at the calcaneal end. You follow it up onto the fibula, it looks really disorganized, and then you can see the ATFL is torn as well. So these two injuries go hand in hand, and I think of the ATFL and the CFL as being a continuous sheet of collagen. The next concept is the concept of the high ankle sprain, and this is where the syndesmotic arrangement between the tibia and the fibula get disrupted. This is the anterior inferior tibiofibular syndesmosis, and this is its posterior cousin. You can assess them both quite effectively with ultrasound, and the key to assessing them is to understand that the angulation of it, the tibial end is far more proximal than the fibular end. So you need to be angling the transducer almost at the patient's opposite knee. And when you're working in the posterior ankle and you're on the posterior fibula, if you then rotate this transducer so it points towards the patient's opposite knee, so in other words, the fibular end of the transducer is more distal, the tibial end is more proximal, you will line yourself up on the posterior inferior tibiofibular syndesmosis just the same. When it pops, it's pretty spectacular because it's a really strong structure. So the patient won't be able to weight bear, they'll have a moon boot, crutches or a wheelchair when they present to you, and it very commonly takes a little fracture with it. So you can see there's a nice little chunk of bone that's come off here as this AITFS has exploded. You can stress it by putting your hand underneath the heel and then providing external rotation. As you rotate externally, if you look at the arrangement between the tibia and fibula, you can see the stress that this applies. And in this example, you can see fat where the ligament should be, and you can also see a couple of little tiny, bright, echogenic avulsions that have come off at the same time. It's a very effective stress test. You notice I've got the knee bent there a bit as well, and I'm just letting the patient just rest their heel in the palm of my hand. Of course, if you've got a ATFL or a CFL injury, it's quite common then to also then have a fibular fracture, and you can see that if you look at the bony architecture of the fibula here, you can see that it's got an actual fracture in it. So always remember when you're doing ultrasound for an inversion injury, not just to look at the ligamentous and tendinous components in the joint capsule, but actually have a look at the orthopedic hardware as well, because both of these patients have distal fibular fractures. The next structure we'll look at is this one here, which is the superior peroneal retinaculum. So it sits across the two peroneal tendons proximal to the calcaneofibular ligament, and you can see in these cases this one's taken a bony avulsion off, and this one's just really thick and black and disorganized. So this is another aspect that you might note in an inversion injury. If you go a little more distal and you follow peroneus brevis all the way down to the base of the fifth metatarsal, you'll notice the peroneus brevis inserts here at this location. And then just slightly on the lateral side of peroneus brevis, there's a second structure that comes in, and this is the lateral band of the plantar fascia. So we very commonly get plantar fasciopathy here on the lateral aspect of the base of the fifth metatarsal, and we also get Jones fractures like this one, where with an inversion injury, you'll have a crack through the base of the fifth metatarsal, and these are two examples. It's the same patient actually, short and long axis of a Jones fracture of the base of the fifth metatarsal. So again, just to highlight the importance of remembering the orthopedic hardware. So these examples I've shown you so far are examples of where the patient has tried to tear their hindfoot, which is their talus and their calcaneum, away from their tibia and fibula. So this is a really common pattern where the hindfoot tries to separate from the tib and fib. So in these patterns you get ATFL tears, CFL tears, syndesmotic tears, and of course deltoid ligament tears that we'll come to. There is, however, another group of patients, and these patients don't try and tear their hindfoot from the tib and fib. They try and tear their midfoot from their hindfoot, and this is known as the Chopart line. So the Chopart line runs through here. It runs between the talus and the calcaneum and the navicular and the cuboid here. And these, of course, are the cuneiforms that make up the rest of the midfoot, and the forefoot is the metatarsals and the phalanges. So there's a natural line through here, and that's called the Chopart line. And you have patients that have intact ATFLs, intact CFLs, but they have torn through the Chopart line as part of a Chopart line failure. And the two key ligaments that tear in these patients are the dorsal talonavicular ligament that runs through here, and the calcaneocuboid ligament that sits here that makes part of the bifurcate ligament with another sling that runs from the anterior tubercle of the calcaneum to the navicular. So the two structures that we look at sonographically are the dorsal talonavicular and the calcaneocuboid ligaments as part of a Chopart line failure. There is, of course, another line through the foot, which is the Liz-Frank line, and that's between the midfoot and the forefoot. And you may have heard of the word the Charcot foot, and a Charcot foot is a diabetic neuropathic foot where the intrinsic muscles have become wasted due to the neuropathy, and then the midfoot starts to fall away from the hindfoot, and so you get a disruption again through here, through the Chopart line. So on a plain radiograph, you can really easily see the Chopart line of weakness here. And so there's our dorsal talonavicular is going to be there. This is the anterior tubercle of the calcaneum, and the calcaneocuboid ligament is going to run through here between that and the cuboid bone. There's the Liz-Frank line. So when I see a patient like this, they're black and blue, I think they must have a fracture, at least an avulsion, if not a proper orthopedic fracture. So I'm thinking about ATFL with a big talar avulsion. I'm thinking about a fractured fibula, a base of fifth fracture, or an anterior tubercle of the calcaneal fracture if it's going to be a Chopart line failure. So this is the calcaneocuboid ligament. There's the dorsal talonavicular there, and that's the calcaneocuboid, and this is what it looks like sonographically. If you take the transducer pressure off, there's a little artery that sits here called the lateral talar artery, and that's a good landmark as well. This is the calcaneum, this is the cuboid. So you can see it's a beautiful, slender, long sling of collagen, and it always fails from this end. It comes off of the anterior tubercle of the calcaneum, and it really commonly takes a decent avulsion with it, and it's notoriously difficult to see on the plain radiographs, unfortunately. So this is our patient with the bruising, and you can see here the anterior tubercle of the calcaneum has been completely disrupted. So it's a very large avulsion fracture, and that's where all of that blood product has come from that has caused that extensive bruising. Again, look at the bruising on this foot. It's really extensive, and the ATFL's intact, the CFL's intact, but when you get to the show part line, you can see that the anterior tubercle of the calcaneum again has been disrupted, and that's where the blood has come from. So it's a really important ligament to look at. So in this patient, you can see both of the ligaments are torn. The dorsal talonavicular has got an avulsion from the navicular, and then the calcaneal cuboid has an avulsion from the anterior tubercle of the calcaneum, which is at the beginning of this video as it runs around again. You can see there's one of the avulsions there, and the other avulsion is here. So this is what I call a show part line failure. So it's where the midfoot has torn from the hindfoot. This is the dorsal talonavicular ligament that's torn again with a significant avulsion from the navicular, but in this patient, when we looked at the rest of the show part line, it was intact. So patients with this type of pattern of injury have usually had a plantar flexion injury that's popped the dorsal talonavicular but left the calcaneal cuboid intact. If there's an internal rotation component as well, which there often is, then you do the calcaneal cuboid at the same time. A really interesting structure that we're playing with at the moment are these extensor retinaculums as they pass through the sinus tarsi. So this is the sinus tarsi of a patient, and when you look in the sinus tarsi, you might just think it's just a triangle of fat, but in fact there is a sling of collagen that wraps around extensor digitorum and then comes down and attaches onto the inside aspect of that anterior tubercle of the calcaneum. So there's one band coming through here and another band through here, and you can see that the deeper band in this case has got a significant sort of hypoechoic change and cystic sort of degenerative change in it, and this is all part of an inversion injury that's damaged that extensor retinaculum apparatus. I think the assessment of the sinus tarsi is a great topic, and it's something we're going to get better and better at as time goes on. If you then go to the medial side of the ankle with an inversion injury, we can have a look here at the deltoid ligament complex. And with the deltoid ligament complex, I really want to keep it fairly simple. The piece at the back of the deltoid ligament, the tibio-talar part, so this is just after the tibialis posterior has left, it's just coming off of the tibia there, and now it's airborne. The structure underneath it, between the two bones here, which is the tibia and the talus, this is the tibio-talar part of the deltoid. And in this case, with an inversion injury, the tibia and the talus have come together and they've crushed this structure here. So this ligament's become crushed. When we see this hyperemia in the acute setting, I call it a post-traumatic hyperemia, so just a result of the trauma. However, when I see the same appearance, say 3 weeks after or longer than that after the injury, I then call it a POMI lesion, a posteromedial impingement lesion, because this is then becoming a chronic synovitis, and it's quite uncomfortable for the patient, even though that their lateral ankle's feeling much better. So that occurs at this part of the deltoid here. This is the tibio-talar part. So you get compression injuries here, but you also get tears of the deltoid, and they happen here. So what I do is I get my index finger and I put my index finger against the anterior edge of the tibia here, and then I put my transducer vertically right behind it. So just here, so I'm lined up pretty much on this tibio-calcaneal component of the deltoid running down here at 6 o'clock, and this is the area I'm looking at. And when I look at what I see sonographically there, I see a deltoid ligament then conjoining with a flexor retinaculum. So it's a combination of a ligament and a retinaculum, so we cheekily call it a liganaculum. That's just a made-up word. But then that inserts here onto the medial malleolus, and that structure there, of course, is tibialis posterior. So it's this liganacular structure that comes up and attaches onto the tibia here that we see being stripped off. So this is an example of a degloving, stripping injury of the flexor retinaculum / medial joint capsule of the ankle, which is in fact the deltoid ligament naturally. They'll also be quite vascular and they'll be very, very tender, so it's a nice clinical diagnosis to make. you can tear also these extensor retinaculum components off. So you can see this almost looks like sandal straps really, and from sort of Greek sandal wear, and you can see the way that they attach here and they attach here onto the tibia and fibula, and it's these attachments here that can be stripped off, and you can see in this video here how this is the extensor retinaculum, and have a look at it. It's actually just sitting in the breeze here. It's no longer attached onto that fibula. So this is a very painful injury. And so when you're doing an inversion injury, have a look at the tibia and the fibula for these extensor retinaculum injuries. And of course, it's also the extensor retinaculum that we see passing through the sinus tarsi, as I mentioned previously. We do miss some things. What other things do we miss? So you might see the hemarthrosis, but we don't typically see the talar fractures. We're quite poor at other fractures as well. The calcaneum and the talus especially can fracture in places we don't have access to. So if you see a hemarthrosis, or if the patient's not able to weight bear a few days after their injury, they probably need cross-sectional imaging. We don't see bone bruising. I think the posterior inferior tibiofibular syndesmosis injury we're getting much better at, so I'm much happier with that these days. We don't see the interosseous membrane injuries that you see going up the calf, and of course we don't see the little chondral injuries to the cartilage sitting on the talus, etc. I hope you've enjoyed this presentation, a short presentation on inversion injury assessment. If you have any questions about this presentation or any other ultrasound questions, you can contact me easily at stayintouch@birdultrasound.com.au. And please visit birdultrasound.com.au, where you'll find a large selection of other webinar-style ultrasound education material covering all sorts of topics: vascular topics, obstetric topics, gynecology, breast imaging, head and neck, etc., as well as, of course, lots of MSK. If you subscribe to the website, use the coupon code ASA and you'll receive a discount at the checkout. Happy scanning, and bye for now.
Thank you, Stephen. Next up is Dr. Wee Chin Chin, who I've had the pleasure to work with closely for many years. She's a senior principal radiographer from Singapore General Hospital with over 15 years of clinical experience in ultrasound. In 2015, she completed a PhD in medical imaging from Monash University in Australia. Her current work encompasses clinical care as well as her research interest in particular ultrasound elastography in the diagnosis and treatment and monitoring of musculotendinous abnormalities. She is a passionate educator and is actively involved in undergraduate and postgraduate education in her role as Associate Professor at Singapore Institute of Technology. With that, I'd like to welcome Chin Chin.
Hello everyone, my name is Chin Chin, radiographer from SGH. Thank you for joining us this evening. Before I start, I would like to thank the organizing committee and Canon Medical for the opportunity to speak at this event. Thank you very much. In this presentation, I'll be sharing our experience in applying some recent advanced techniques in musculoskeletal ultrasound, and I'll be highlighting the expanding clinical applications of ultrasound elastography and microvascular imaging. Many disease processes result in changes in tissue elasticity. Current conventional ultrasound techniques provide information on anatomy, morphology, and vascularity of tissues, but really there's no information on the elastic properties. So ultrasound elastography measures elastic properties of tissues, and it provides objective measure of tissue stiffness. It overcomes the subjectivity of manual palpation. Generally, there are two types of ultrasound elastography techniques: strain elastography and shear wave elastography. So for strain elastography, the compression is done manually and externally using transducer. This technique provides qualitative data on tissue stiffness. Whereas in shear wave elastography, the transducer transmits a high intensity push pulse, and when the push pulse interrogates with the tissue of interest, it will produce shear wave that propagates in 90 degrees direction to the push pulse. The ultrasound system can calculate the propagation velocity of the shear waves, and the shear waves is directly proportional to the tissue stiffness, in which the higher the propagation velocity, the higher the tissue stiffness. So this technique provides quantitative data of tissue elasticity either in units meter per second or kilopascal. So what is the pathological basis behind strain elastography? When a tendinous tissue is diseased, it is characterized by extensive mucoid or lipoid degeneration. And all these changes or alterations may cause softening of the insulted area. In neoplasm, on the other hand, the increased cellularity and fibrotic changes may cause hardening of lesions. Here is an example of a normal Achilles tendon in a healthy volunteer. B-mode ultrasound on your left shows homogeneous tendon fibers with linear fibular echo patterns. There's normal tendon thickness. On your right is the elastogram. So on the color scale, red represents soft areas, whereas blue is hard, represent hard tissues. The compression indicator or quality indicator provides real-time feedback to operators whether the compression applied during real time is appropriate. So we can appreciate that the Achilles tendon is blue color coded in this case, which indicate hard and healthy tendon texture. Here is a case of a middle-aged man presented with left Achilles tendon symptoms for 2 years. Clearly, there is fusiform thickening at the mid portions of the Achilles tendon, and the dorsal fibers are markedly hypoechoic and heterogeneous looking, mostly affected by the pathological process. There's increase in neovascularity consistent with possible inflammatory reaction. The corresponding sonoelastogram or ultrasound elastogram shows intratendinous softening, especially at the dorsal fibers, and this is compatible with tendinopathic changes due to the presence of mucoid or lipoid degeneration. We also evaluated using shear wave elastography, and here's the asymptomatic side, right side that was taken for comparison purpose. To generate these shear wave readings, we place the caliper on the elastography elasticity map here, and the system shows the shear wave readings of more than 100 kilopascal. Remember, the propagation speed or the converted kilopascal values are directly proportional to the tissue stiffness. So the high shear wave values here reflect a stiff or hard, healthy tendon properties. The symptomatic left side shows a markedly lower shear wave values compared to the asymptomatic right side. And this reflects its soft tendinopathic properties. Here's another example of a 67-year-old male who was kicked by a horse with a significant fall on his left side. We applied dynamic finger compression technique to assess the region of interest and see if there's contour deformity. And if yes, this would suggest underlying tear. Now we have an additional simple tool that we can use to confirm our diagnosis. And this tool gives us information beyond morphology. So clearly, on the elastogram, there is soft areas within the supraspinatus tendon that extend from the bursal surface to the articular surface. And this is highly suggestive of a full thickness tear, which subsequently confirmed on histology. Here's our early preliminary experience on the diagnostic performance of ultrasound elastography in confirming the clinically diagnosed Achilles tendinopathy. This table shows the sensitivity, specificity, and accuracy of B-mode ultrasound, elastography, color Doppler ultrasound, as well as the combination of techniques. We found that combinations of B-mode ultrasound and elastography achieved higher sensitivity, specificity, and accuracy compared to routine combination techniques of B-mode ultrasound and color Doppler ultrasound. In a separate study, we also found intratendinous delamination and softening, as demonstrated on elastography, has prognostic value in predicting future occurrence of symptomatic Achilles tendinopathy in a group of asymptomatic elite football players. In the next few slides, I'll be sharing more info about the superb microvascular imaging techniques, or in short, SMI. Conventional color Doppler or power Doppler ultrasound techniques evaluates tissue vascularity and detect possible inflammatory conditions. These techniques, however, have limited sensitivity for slow flow imaging. SMI is an innovative Doppler technique employing a unique algorithm for imaging minute vessels with slow velocity. SMI has two modes of imaging, namely color mode or CSMI, which displays the flow components in color overlaid on the B-mode image. Monochrome mode or MSMI, which focuses only on the detailed vasculature by subtracting the background image, as shown here. So, image on your left is CSMI or color mode SMI, and image on your right is monochrome or MSMI. In conventional Doppler imaging, wall filter is applied to remove clutter or tissue motion artifacts. This results in a loss of genuine low-velocity blood flow components. SMI uses a special algorithm that is able to identify and selectively remove only the clutter or tissue motion artifacts while preserving the low-velocity blood flow. So SMI allows visualization of tiny vessels with slow velocity flow without the need for contrast agents. As you can see from the illustration below, SMI can display microvascular flow at the periphery of the vessels, whereas conventional Doppler imaging can't. There's also less motion artifacts compared to conventional Doppler imaging. So back to our Achilles case. Here, grayscale ultrasound clearly demonstrates good details of the thickened and heterogeneous hypoechoic looking Achilles tendon. The corresponding sonoelastography also demonstrates intratendinous softening. And as we can see, there are prominent vascularity seen within the tendon, suggestive of inflammatory response. Interrogation with SNI shows rich architecture of the intratendinous neovascularity, and there is significant hyperemia within the tendon, with vessels entering the tendon from the Kager's fat pad. And this is typical of mid-substance Achilles tendinopathy. Recent studies have shown that the enhanced microvascular volume is associated with functional disability scores measured on VISA. The authors concluded that the microvascular flow may be valuable in the diagnosis and treatment monitoring of tendon inflammations by monitoring quantitative changes in vessel density over time. Here is another example of an 81-year-old female presented with left forehead lump. We can see that the superior grayscale image with excellent near-field resolutions obtained using the high-frequency I-series 24 MHz transducer. The various tissue layers such as epidermis, dermis, subcutaneous fat, superficial fascia, and bone layers are clearly demonstrated with great anatomical detail. We can appreciate that the lump is oval in shape and hypoechoic looking, lying within the dermis layer. SMI shows the enhanced high-resolution microvascular architecture as compared to conventional color Doppler ultrasound. And this allows greater diagnostic confidence and accuracy in detecting these tumors which are very superficial in location. We also interrogated this mass using elastography. So, dual screen, left image, elastography shows that the mass has distinctly hard texture, and image at the bottom, it displayed high shear wave values of more than 60 kilopascal on shear wave elastography. So this mass was subsequently proven to be BCC, which is the most common skin cancer. Skin lesions are readily visible to our naked eye. Usually, clinical examination is sufficient to determine whether a lesion has to be removed. However, ultrasound imaging can provide additional information such as thickness and lateral margins or extension of the mass, fascial integrity, homogeneous or heterogeneous structure. This information is valuable to guide surgical planning and management. The microvascular architecture as shown on SMI can also help to predict its aggression potential. As for the application of SMI in small parts, here is an example of a 52-year-old female with biopsy-confirmed papillary thyroid carcinoma of the right thyroid nodule. Here. She went for ultrasound-guided RFA in December 2016. So these are follow-up ultrasound images 6 months following the RFA. So here we can see that SMI detected microvasculature which likely represent capillaries of the residual thyroid nodules after RFA, which may indicate incomplete ablation. And bottom, these are the corresponding images of the same nodule interrogated using conventional Doppler ultrasound techniques. Here we can appreciate that the microvasculature flow within the nodule was better demonstrated on SMI as compared to color Doppler ultrasound or power Doppler ultrasound. So patient went for ultrasound-guided RFA again in 2017 September. On subsequent follow-up ultrasound, we can see that there's no microvascular perfusion within the ablated zone. And there's also reduction in nodule size at this follow-up. This case shows that SMI can be potentially used for monitoring curative effect of ablation for thyroid nodules. So in our center, we studied the prevalence of neovascularity in rotator cuff tendinopathy using SMI, color Doppler and power Doppler ultrasound. We recruited 59 patients presented with clinical rotator cuff symptoms and evaluated these patients with grayscale ultrasound, color Doppler and power Doppler imaging as well as SMI. We analyzed the prevalence of neovascularity and grayscale changes on duplex imaging, the relationship between neovascularity seen on color Doppler, power Doppler, SMI, and pain and functional disability scores were also determined. So we found that SMI is more sensitive in demonstrating neovascularity in patients with rotator cuff tendinopathy, and SMI demonstrates better correlation with clinical symptoms. This was a case taken from our study. Here are color and power Doppler ultrasound images in a patient with left supraspinatus tendinopathy. The patients presented with VAS pain score of 8 out of 10. The patient was quite painful. And as you can see, grayscale ultrasound of the symptomatic left shoulder shows a markedly thickened and heterogeneous tendon with intratendinous hypoechoic changes. However, there are no gross increase in vascular signals seen on power Doppler ultrasound and color Doppler ultrasound. So here is the dual mode SMI, which demonstrates prominent neovascularity, and we can see that there are more than 2 linear new vessels seen on SMI, which were not seen on conventional Doppler imaging modes. So we concluded that SMI detects more vessels than color Doppler or power Doppler ultrasound in rotator cuff tendinopathy patients. It may allow increased sensitivity for early detections of tendinopathy and monitoring of its dynamic changes under therapy. In conclusion, advanced ultrasound MSK techniques such as ultrasound elastography and SMI are good supplementary tools to conventional ultrasound. They have potential applications in early diagnosis, predicting impending injuries, and monitoring progression of disease. Before I end, I would like to thank the following people for making this presentation possible. Thank you very much for your attention.
Next, I would like to welcome back Mr. Stephen Bird, who will be sharing with us his novel talk on A Tale of Two Muscles.
Welcome to this presentation, A Tale of Two Muscles, where I'm going to explore two muscle groups that I find both complicated and fascinating. The first is rectus femoris, which is the most anterior of the quadriceps muscle group, and it has an architecture design that is almost like a muscle inside a muscle. Proximally, it has two tendons. The first tendon, which is called the direct head tendon, has its origin from the anterior inferior iliac spine. It's drawn in yellow here, and it smears down on the anterior aspect of the muscle. It then has a second tendon, an indirect head tendon, that comes from the superolateral aspect of the acetabulum. It's drawn here in this olive colour, and it extends right down through the middle of the muscle with a very thick collagen band that extends really distally, about 3/4 of the way down through the distance of the muscle. We then have a posterior tendon, and the posterior tendon makes the most anterior component of the quadriceps attachment onto the base of the patella, and then as it comes back, it forms the posterior border of the muscle and extends a long way along the muscle. So what we really have is sort of a muscle inside a muscle, because the indirect head tendon forms its own muscle inside a second muscle which has got a proximal and a distal tendon. So when we have a musculotendinous junction tear, and we see the tear being anteriorly located like this, it's really a musculotendinous junction tear of the direct head tendon. More commonly, though, we see the indirect head tendon fail, and that's in this area here. So it's going to be the tissue that is immediately surrounding this thick raphe of collagen that's coming down through the central component of the muscle. And then occasionally we're going to see posterior tears, which many would describe as a myofascial tear. However, I'm going to describe them as a distal musculotendinous junction failure coming from this distal tendon. So if we have a look at the muscle in cross-section and we start at the top, we can see that we have the direct head tendon in yellow sitting immediately on top of the indirect head tendon in that olive colour. And then as we follow it down through the muscle belly itself at these cross-sections, you can see the way that the direct head tendon sits anteriorly, the indirect head tendon sits inside the muscle, and this bit of orange muscle here belongs to the indirect head tendon, whereas the surrounding red muscle belongs to the direct head tendon. So we have a muscle inside a muscle. And then as we head more distally, eventually we see this bit of green tendon forming on the posterior wall, and this is the distal tendon of rectus femoris. So in other words, a tear that happens here is going to be a direct head tendon musculotendinous junction tear. A tear that happens here is going to be an indirect head tendon musculotendinous junction tear, and a tear that happens here on the posterior border is a distal tendon musculotendinous junction tear. So this is the pathology we can see. This is the direct head origin, and this is a simple case of tendinosis. So it's hypoechoic and vascular, swollen and painful for the patient. This is hydroxyapatite. So this is a crystal deposition disease, very, very painful for the patient, affecting again the direct head tendon. And the patient will really present with anterior hip pain, but the pain will actually be slightly lateral to the anterior hip joint itself. This is an avulsion injury, so this is where the anterior inferior iliac spine, this bone here, has failed, and it has actually allowed an avulsion to come from it. This is just a hematoma, and the reason that the retraction is so small here is because the indirect head tendon is still holding everything together and holding it in place. In this case, you can see the indirect head tendon has failed. You can see an avulsion that's come off the superolateral aspect of the acetabulum, and you can see a retracted and puckered up indirect head tendon. This is probably the worst injury of all, and this is where the indirect head tendon here looks really detensioned, and then when we follow it back to the muscle itself is not at all connected to that tendon, and in fact the direct head tendon is also suffered a tendon failure. So both the direct and indirect head tendons have become disconnected from the muscle belly itself, and this patient will need to have probably some surgical consideration. There's three types of injuries that you get in muscles. There's myofascial injuries, which I'm not a big fan of. I think I allocate most of these as a musculotendinous junction injury, where the tendon is running along the periphery of the muscle. Then we have the musculotendinous junction tear itself, where the muscle tears from the central tendon. We see this very commonly in rectus femoris. And then it's very important to establish if this central tendon itself has remained intact, or if in fact it has popped and we've lost the scaffolding running through the internal part of the muscle. And this is a very important differentiation. So this is a central tendon here, so the indirect head tendon, and you can see it's intact. It continues all the way down through beautifully. However, the tissue around it is really echogenic and blushing, and that's because there's a significant musculotendinous junction injury here, but with a maintenance of the central tendon. In this case, again, you can see the way that that central tendon remains intact. However, there's a significant hematoma adjacent to it. Again, a musculotendinous junction injury with an intact central tendon. In this case, though, you can see this is a more significant injury. If you follow the central tendon down, it actually just terminates in a hematoma, so it's actually popped at this level here. And then a little further distally, you can see it re-establishes itself, and you can see there it is again there. So this is where the central tendon itself has popped, and this is a more significant injury. This is a case of a distal musculotendinous junction injury, where we can see on the posterior border here of the rectus femoris muscle, you can see this cystic change, this hematoma, and this is where the muscle has pulled itself away from this distal tendon. So the tear is in this green area here, and this is a less common injury, but at least it's we can allocate it correctly. And this is a complete failure of the distal tendon. You can see that there's a stump here, and then the other stump is really just sort of hanging off the base of the patella here. So you've got this sort of superficial laminate coming from the patella here, and when you follow it proximally, you'll see it terminates in a stump as well. So this is where the distal tendon has ruptured, and you can see it's bled extensively, causing this very large hematoma in this space here. And then this is the last unique type of injury you can have, and if you follow that central scaffolding of that indirect head tendon down through the muscle here, you can see that it's beautifully intact, and you can see the actual muscles attached to it is fairly reasonable as well. However, the indirect component of this muscle has degloved from the direct head component. So in other words, this orange piece of muscle here has actually pulled itself away from the red piece of muscle. So this is the degloving injury, really unique to this muscle. We're going to walk through the basic anatomy of the proximal end of the rectus femoris muscle, just starting here with an anterior hip view, your standard anterior hip picture, and then turn transverse on that so that we're now 90 degrees to the femoral head and walk up onto the iliopectineal eminence. We can see the iliopsoas apparatus. If I then come laterally, you'll see this peak in the bone, and this is the anterior inferior iliac spine. If I come down from that slightly, you can start to appreciate that this is the rectus femoris muscle origin here. So as we come back up to the top, anterior inferior iliac spine, and go long axis on it, you can see we have this beautiful collagen here, and this collagen here belongs to the direct head tendon for rectus femoris. We can see this grey area here, and this is because of anisotropy. This is the indirect head tendon here. So let's come back into transverse. We're going to come down into the muscle. As we come down into the muscle, you can see what's happened here. You've got one tendon sitting across the top, so this thick layer of collagen here, this is the direct head, and then we've got this vertical raphe of collagen, which is sitting inside the muscle. This is the indirect head collagen. So if I want to then follow this indirect head collagen, if I turn 90 degrees on that thick band of collagen, you can see it here so beautifully, and now I'm going to follow it proximally, and you're going to see that instead of going to the anterior inferior iliac spine, it starts to head downwards and laterally. So I can just keep following it here, and you can see the way it's coming down through here. And now this is in fact the lateral hip joint capsule here. This is the gluteus minimus tendon, and this is the indirect head of rectus femoris. This is its origin here on the supralateral aspect of the acetabulum. So indirect head coming down, and we can follow it all the way down into its muscle belly. And then you can prove that that is the indirect head tendon by simply turning 90 degrees, and you can see that the way that collagen belongs to this central raphe here. The distal tendon of the rectus femoris apparatus forms on the posterior border of the muscle belly here. So I've already established the fact that this is the direct head tendon here, this is the indirect head tendon here. But if we now look at the posterior border here, we can see as we head distally how this thickens up. So you're getting this thickening up of this hypoechoic layer here. It's from here all the way to here, and this is the distal tendon. So if we follow it all the way down, in fact we end up here. And this is the quadriceps tendon, and you can see that this collagen here belongs to the rectus femoris, and that this in fact makes the most superficial layer of the quadriceps tendon. So you can see the way the quadriceps tendon has 3 layers, and the most superficial layer, if you follow it back and come back into the short axis, you can see the way that that superficial layer here becomes the posterior wall of rectus femoris. So in other words, if you have a tear along the posterior wall of rectus femoris, this is going to be allocated to a distal tendon, musculotendinous junction failure. The next muscle group that I'm going to consider is the medial calf group of muscles, part of the trisurate that makes up the Achilles tendon. We're going to have a look at the way that medial gastrocnemius finishes its insertion to form this new concept here called the free gastrocnemius aponeurosis, which then goes on to become the Achilles tendon. So this concept of the free gastrocnemius aponeurosis refers to this medially placed proximal end of the Achilles tendon within about 2 centimeters from the tip of the medial gastrocnemius muscle. So when we have a tear of the tennis leg type, you can get a very common type of tear where the medial gastrocnemius simply tears off of its aponeurosis. And as it does this, it might come clean away from the aponeurosis, leaving the underlying aponeurosis intact. So in other words, the collagen scaffolding remains intact, or it may in fact also damage and disrupt that collagen scaffolding that it's attaching onto. A more serious injury, though, is when we have a tear of the free gastrocnemius aponeurosis. And I've always described this as a match head type tear, because when we tear the free gastrocnemius aponeurosis, so this area here now has a tear in it, we get this puckering up of the Achilles tendon distal to it, and also the aponeurosis proximal to it, leaving 2 puckered up areas of collagen which look like the head of a match. Of course, the most serious injury you can have is far more distal, and this is your typical Achilles tendon rupture. So if we have a look at the anatomy now with this new understanding, this is the medial gastrocnemius muscle, this is the soleus muscle, and this area through here is a potential space with the Achilles tendon coming up through here, and we have a group of aponeuroses. So the first one is this aponeurosis here, and this is the medial gastrocnemius aponeurosis, and this is what the medial gastrocnemius attaches onto. The second one is this aponeurosis, which is the This second one is the soleus aponeurosis, and this is where the soleal muscle attaches onto its aponeurosis. The third area we have is this area here, which is the free gastrocnemius aponeurosis, and this is at the end of the gastrocnemius insertion, an area of a couple of centimeters length that is really the proximal medial aspect of the Achilles, and then anything distal to that is called an Achilles rupture. So the types of injuries we can have is, this is your baseline sort of entry-level injury where the medial gastrocnemius pulls itself away from its aponeurosis, however the aponeurosis remains intact. A slightly more serious injury is when the medial gastrocnemius tears from its aponeurosis, and the aponeurosis now has a defect in it. So we have a defect in the aponeurosis. So what's important sonographically now is to look at these aponeurotic lines to decide whether or not they've remained intact or whether they've become ruptured. The third type of injury is where soleus comes away cleanly from its aponeurosis, leaving the aponeurosis intact. And then, of course, the next grade of injury is where the soleal aponeurosis fails and it tears a hole in this as well. An even more serious injury is what I call the match head injury, and this is where the free gastrocnemius aponeurosis fails, and you get a puckering up of collagen at either end and a little defect gap in between. And this is a failure of the free gastrocnemius aponeurosis, a very, very common type of injury, and takes some significant rehabilitation. So this is an example of a gastrocnemius tear from its aponeurosis, but if you look at the double white line here, the double white line remains intact all the way through. So simply the muscle has come away from the aponeurosis, but I feel like in this case the aponeurosis has survived the trauma. If you look at this case though, you can see here we've got this double white line, and then when we get to the area of injury, which is here, I think you can see the aponeurosis has failed. There's one end of it there, and the other end of it's there. So there's a big defect here in this medial gastrocnemius aponeurosis. So this is a more significant injury to the previous one. And then this is more significant again, and this is a free gastrocnemius aponeurosis rupture. So this happens distal to the distal insertion of medial gastrocnemius, and you can see the puckered up FGA here, so looking like a match head, and then you can see the other end of the aponeurosis is actually retracted back up underneath medial gastrocnemius. But this match head sign, I think, is very sensitive for a free gastrocnemius aponeurosis rupture, and you can see underneath it here the plantaris tendon goes through beautifully. I really don't believe anymore in plantaris tears at this level. I think really it's been a bit of a misnomer really, and I think we've been overcalling them. And I think when it's a true plantaris tear, you can see that happen distally. And I think for a long time we've been calling this free gastrocnemius aponeurosis tear and retraction into the match head. We've been calling that the plantaris tendon incorrectly. So this is a classic short axis view of a free gastrocnemius aponeurosis. You can see the short axis view of the match head there. You can see the disruption of the medial gastrocnemius. And when we turn long axis, you can see this flaccid and detensioned FGA just sort of hanging in the hematoma there. And of course, you can see the plantaris quite separately and happily going underneath it all, not at all involved in the trauma here. And this is the same case, and you can see the hematoma here at the distal end of the medial gastrocnemius. This blood will extend up through the space between medial gastroc and soleus, the same space that contains the plantaris tendon and the same space that a deep ruptured Baker's cyst will inhabit. But there's the clue here, there's the match head, that's the retracted end of the FGA. This is a significant injury. So again, we have a free gastrocnemius aponeurosis tear here. You can see there's the match head there. You can see the puckered up collagen, the large hematoma, and then a normal plantaris tendon passing underneath. And this is the really common pattern. You're going to see these all the time, and now you're going to be able to describe them correctly and give them the correct grading. This is a simple but nasty Achilles rupture, and you can see that this is more distal, of course, so this is beyond a couple of centimetres from the insertion of medial gastrocnemius, and this is a complete Achilles rupture, showing the classic paradoxical movement with dorsiflexion and plantar flexion of the ankle joint. And here's another Achilles rupture, but this one you can see it's quite proximal, so it's getting up towards the free gastrocnemius aponeurosis, but it's more than a couple of centimetres distal to it, so I'm still going to call this a proximal sort of muscular tendinous junction type complete rupture of the Achilles tendon, and this will be treated like an Achilles rupture rather than a free gastrocnemius aponeurosis, although it was rather proximal. We'll just walk through some of the important anatomy to do with a tennis leg injury or a medial calf injury. This is the medial gastrocnemius muscle, and this is the soleus muscle, and in between them you can see there's two white lines. The superficial white line is the medial gastrocnemius aponeurosis, and the deep white line is the soleus aponeurosis. Now, the medial gastrocnemius is attached to its aponeurosis, as is soleus. So when we have an injury to the medial gastrocnemius, it can pull away from that white line, and with the white line staying intact, so in other words, the scaffolding, that collagen stays intact, or in fact, it can damage that scaffolding, and you can have a rupture of that white line where you have a aponeurosis failure as well. So they're the two types of injuries that we're going to really commonly see with a tennis leg injury. You'll notice as I scan through this, you get to a point here where we can see we've now got multiple lines here, and that's because we're now lined up on the plantaris tendon. So this is the plantaris tendon passing through here. Not everybody has one, but this is the normal plantaris tendon. As I drift off of that, because it's very small, you see we're back to just two white lines. If I then come distally, you can see the way that this, there's the distal tip of gastrocnemius there, and all of a sudden now, these two white lines are turned into a much thicker piece of apparatus here. Now, this thicker piece of apparatus that's within, say, 2 centimetres from the tip of the medial gastrocnemius insertion, this is known as the free gastrocnemius aponeurosis, and this is really the proximal portion of the Achilles tendon. So injuries to this are quite common. So you get a rupture, a tear of the free gastrocnemius aponeurosis, and that's when we get what I call the match head sign. So you're going to see a round, retracted, puckered up match head of collagen, and that's because the Achilles tendon proximally has been torn. If we turn transverse on it now, here's the medial gastrocnemius, there's the plantaris, and you can see this thick layer forming through here, and it's getting thicker and thicker, this quite hypoechoic thick layer. This is the free gastrocnemius aponeurosis that's formed here. And if you follow that distally, you can see that gets thicker and thicker again, and then eventually you can see what's happening now, it's turning into the Achilles tendon. So a failure of the free gastrocnemius aponeurosis is very much akin to a tear, a partial tear, if you like, of the medial component of the proximal end of the Achilles tendon, and that's why it's a significant injury for the patient. I hope you've enjoyed this presentation, A Tale of Two Muscles. You can contact me anytime at this email address. Stay in touch at birdultrasound.com.au, and please visit birdultrasound.com.au, the website where you'll find a wide range of webinar-based educational material covering all sorts of topics, not just musculoskeletal, but lots of other different topics as well. If you use the coupon code ASA when you go to purchase your subscription, you'll receive a discount because you've attended this meeting. Happy scanning, and bye for now.
Hello everyone. Thanks for still staying with us. Now allow me to introduce our next and also our last speaker, Dr. Meng. Dr. Meng is a specialist accredited diagnostic radiologist practicing at the Diagnostic Radiology Department at Singapore General Hospital, or SGH. She completed a fellowship in musculoskeletal radiology at the Orthopedic Centre at Oxford, UK in 1993. She's currently the Senior Consultant Radiologist at SGH with a special interest in musculoskeletal radiology, ultrasound, and radiology IT solutions. So without further ado, let us now welcome Dr. Meng.
Good evening, everyone. Thanks for joining us tonight. I'm Meng, diagnostic radiologist from Singapore General Hospital. I'd like to thank SGCR Wires and Canon Medical for inviting me to give this presentation. I'll be talking about MSK ultrasound with MRI correlation and covering some of these areas, comparing MSK ultrasound to MSK MRI, some of the applications, some case examples to illustrate these points, and some of the limitations and challenges we face. Both ultrasound and MRI have no ionizing radiation. Ultrasound is relatively cheap compared to MRI. Ultrasound is also well tolerated. On the other hand, MRI tends to be noisy and patients require to remain still for long periods of time, which can be a challenge. Ultrasound examinations are portable compared to MRI, which requires the patient to come down, and therefore ill patients may not be suited for MRI. High-resolution images of superficial structures can be obtained on ultrasound as well as on MRI, but in MRI, thin sections may be required, which take a much longer time to acquire. Static examinations, vascular studies, color flow, elastography, and dynamic examinations can be performed on ultrasound, and dynamic examinations are particularly useful in ultrasound. Although MRI can perform elastography, this is very experimental for musculoskeletal system. Dynamic examinations can be performed. These are complicated and therefore rarely used in clinical practice. Metal implants do not cause a problem for superficial structures on ultrasound. On the other hand, MRI can cause artifacts, although modern sequencers such as MAS have managed to dramatically reduce these. Soft tissues are eminently suitable for ultrasound examination, and we perform usually targeted scans and particularly on superficial structures. Foreign bodies are well evaluated as well as small benign masses. MRI, on the other hand, is suitable for soft tissues and has the advantage of evaluating the bones, and it's also better to obtain a global view of structures, deep structures, large masses, and malignant tumors. Some of the areas that we assess on ultrasound involve the superficial structures as seen here. And just to note that although the bone can be evaluated, this is only on the surface. And although I have no much experience in pediatrics, just to mention that pediatric indications are similar to the adults, and they also have been used to assess for subtle occult fractures. In the infant, it's been widely used to assess the spine for spinal dysraphism and developmental hip dysplasia. Tendons are one of the areas that we evaluate, and the shoulder is one of the commonest examinations under the MSK ultrasound portfolio. Chronic repetitive trauma leads to tendon degeneration and tendinosis of the rotator cuff, which over time may result in tendon tears. This particularly affects patients over the age of 40 years. Occasionally, tears may also occur due to acute injury. Here is an example of a rotator cuff. Here's a normal supraspinatus tendon as an echogenic structure, and we can see this hypoechoic area due to a high-grade partial thickness tear with some intact basal-sided fibers over here. On the right, we can see a full thickness tear of the supraspinatus tendon with fluid and debris in the cleft. In addition to assessing the thickness of the tear, it's important for us to assess size and extent to help the surgeon plan surgery better. Here we can see a massive tear with non-visualization of the supraspinatus tendon on the longitudinal view, also seen on the correlative MRI. On the transverse projection, we can see that the tear involves the supraspinatus and infraspinatus tendons, and this is also seen on MRI, which also appears to involve the teres minor. The size of the tendon is important to help us assess the possibility of repair. Similarly, the torn tendon edge is important to evaluate, and here we can see an example of the infraspinatus musculotendinous junction, which looks very unhealthy. It is thickened hypoechoic with areas of increased echogenicity both on the longitudinal and transverse images. On MRI, we see the same ratty-looking myotendinous junction. In addition, we also evaluate the muscle because the muscle has impact on the results of tendon repair. The muscle has been assessed on CT originally by Gutalia and then subsequently by Fuchs et al. On MRI. We also can evaluate the muscle on ultrasound, and here is an example where we can see marked atrophy of the supraspinatus muscle with fat replacing the space both on ultrasound and on MRI. We can also see that fat infiltrates the remnant fibers as seen as this echogenic area, and it is seen as increased white signal on MRI. In the wrist, this patient who presented with suspected ECU tendon subluxation was evaluated on MRI, and here we could see that there was tendinosis of the ECU, but the tendon does not appear subluxed on MRI. Therefore, ultrasound was recommended to confirm the ECU subluxation, and we can see on the examination that initially the ultrasound tendon is nicely located in its groove, but on ulnar deviation and supination, we can see the tendon subluxing forwards in both the static and the dynamic examination, as you can see it here. The hand is a suitable area for assessment by ultrasound because of the superficial structures involved. The sagittal band forms a cylindrical girdle which encircles the metacarpal head. It originates on the volar side at the volar plate and intermetatarsal ligaments and wraps round the metacarpal head, inserting on the extensor tendon dorsally. It can be injured by trauma, particularly flexion and extension under forceful resistance, lacerations, and a direct blow to the metacarpophalangeal joint. Atraumatic injuries can also occur from inflammatory arthritis such as rheumatoid arthritis. And here is an example of a 25-year-old male with a sartasic injury. You can see the extensor tendon here, and we can see the abnormally thickened sagittal band over here as a hypoechoic structure. There appears to be an area of increased echogenicity here, which may represent a tear. On forced flexion, we can see that the tendon is subluxed to one side on ultrasound. This is also seen on MRI, where we can see the normal complex on the ring finger, but in the middle finger, we can see that the sagittal band appears abnormal, and on clenching the fist, the tendon subluxes, and we can see again the defect in the sagittal band here. The nerves are suitable for MR evaluation, especially in the upper limb where they are superficially located. And here is a patient who had ulnar neuritis on flexion of the elbow. MRI was performed as a result, and it shows ulnar nerve situated normally in extension, whereas in flexion it subluxes anteriorly. However, it was not certain whether there was involvement of the medial triceps, and therefore dynamic ultrasound examination was recommended, which shows indeed that the ulnar nerve here dislocates anteriorly, and together with it, the medial head of the triceps over here. Although the bones are not usually assessed by ultrasound, we can assess the bone surface fairly well. Here's an example of a patient with anterior dislocation of the shoulder, and on the reduction film you can see a Hill-Sachs lesion. This you can see is well seen as a defect in the posterior aspect of the humeral head on ultrasound, and the infraspinatus tendon was evaluated and shows a high-grade partial thickness tear near its insertion. And this was confirmed on MRI, where you can see the very ratty-looking infraspinatus tendon with some intact fibers superficially and the Hill-Sachs lesion again. Likely benign masses, particularly in the hand and knee, are often evaluated by ultrasound. And here we look at cysts and bursae. We can also look for benign tumors of the hand tumors are often benign, and which is why they are often evaluated by ultrasound. So here is an example of a patient with a lump on the dorsum of the hand, and on ultrasound we can see a homogeneously hypoechoic mass surrounding the normal tendon. Knowing that solid tumors of the tendon, giant cell tumor is a very common cause, and this was suspected therefore to represent a giant cell tumor. On MRI we can see a similar appearance of a low T1 and high T2 mass surrounding the extensor tendon. On the transverse images we note that the mass was rather large, extending from the second to the fifth metacarpal bone, and therefore MRI was recommended to better evaluate the extent of the lesion, which indeed actually shows a similar appearance, and on post-contrast examination we can see that the mass is heterogeneously enhancing. Ultrasound is very good for assessing small tumors of the hand, and a glomus tumor is such an example. Here we can see a patient who had a point tenderness over the distal phalanx for 3 months with a purplish hue. Clinically, this was suspected to be a glomus tumor, and this was confirmed on ultrasound to be a well-defined hypoechoic mass with increased vascularity, and measured 4 mm. Here we have an example of a shoulder lump which fluctuated in size with exercise and therefore thought to be due to shoulder bursitis. On radiographs, it actually appears to be a large mass with radiolucency suggestive of a lipoma. On ultrasound, this was confirmed to be an echogenic mass with thin internal septations, in keeping with intramuscular lipoma of the deltoid. However, because of some peripheral heterogeneity and the size of the lesion measuring 7 cm, MRI was recommended. MRI indeed showed a lipomatous tumor which showed nice fat suppression, but the inferior aspect of the lesion shows a low T1 and high T2 signal area, suspicious of a liposarcoma. Ultrasound elastography showed that the mass was of intermediate stiffness. Surgery was done to excise the tumor for suspected malignancy, but it indeed ended up to represent an intramuscular lipoma. Ultrasound is used to evaluate benign tumors and also for their progression. So here is an example of a lesion thought to be a benign neurogenic tumor. Over time, this lesion grew in size by about 0.4 mm over 4 years. Here is an example of a superficial radial nerve schwannoma which was excised and subsequently recurred, and ultrasound confirms the recurrent lesion. Extensive swelling is not an ideal indicator for MRI. Here we find a 79-year-old patient with ESRF, hypertension and diabetes, and TB in the 80s. He presented with fever of unknown origin with right hand and wrist swelling for 3 weeks. Ultrasound actually showed a echogenic mass with increased vascularity on the dorsal aspect of the wrist, which was also confirmed on MRI, which also seemed to show some fluid in addition to synovitis. On the volar aspect of the wrist, we can see an echogenic mass with increased vascularity as well, And we also note the presence or involvement of the pronator quadratus muscle. On the transverse view, we can see anechoic areas suggestive of liquefaction and abscess formation. This is actually confirmed on MRI over here, but MRI also shows involvement of the distal radial ulnar joint, not appreciated on the ultrasound exam. In addition, MRI shows involvement of the carpal bones and metacarpal bones not seen on ultrasound, and we can see the presence of periostitis as well. This indicates osteomyelitis, which was not appreciated on ultrasound, in this case with tuberculosis, synovitis, abscess, and osteomyelitis. MRI is also not suitable for large complex masses, and here is an example of a large mass in the infraspinatus muscle, which is heterogeneously hyperechoic with areas of anechoic spaces, which on color Doppler are shown to be due to vascular spalaces. As a result, MRI was recommended, and indeed it does show that in addition to involvement of the infraspinatus, actually the tumor arises from the scapula and involves the subscapularis muscle, and this turned out to be a metastatic renal cell carcinoma. Foreign bodies which are superficial in location are well evaluated and detected and localized by ultrasound. And here we see a linear echogenic focus of a non-radiopaque foreign body, which is depicted on ultrasound but could not be seen on radiographs. And this only measured 2 millimeter. Ultrasound was done on day 2 of birth, and it shows the spinal cord tethered to the dorsal surface of the spinal canal at the S1-2 level on ultrasound, and it also shows dilatation of the central canal. MRI, which was done 5 months later, also shows tethering of the cord, and it also shows progressive dilatation of the central canal. In addition, within the caudal spinal canal, we can see an echogenic mass on ultrasound, which correlates with a intraspinal lipoma on MRI. Some of the limitations and challenges we face: firstly, ultrasound is highly user-dependent, and accessibility to the area of interest must be possible. Bones are not well evaluated on ultrasound, especially the internal structures. Penetration and deeper structures are also not evaluated. It can be time-consuming for ultrasound to assess large areas of abnormality, and there's a heavy reliance on normal anatomy to guide the ultrasound exam. Artifacts such as anisotropy can also mimic pathology on ultrasound. In summary, I've tried to cover some of the areas of evaluation on ultrasound of the musculoskeletal structures, and these include tendons, muscles, ligaments, and nerves, synovitis and effusion, as well as evaluating of likely benign masses. I've shown some examples of musculoskeletal ultrasound with MRI correlation, and to highlight some of the advantages of this technique, which include its well-tolerated and portable, high-resolution images of superficial structures can be obtained. Dynamic ultrasound is particularly useful, and it can evaluate the stiffness and vascularity of musculoskeletal structures. Some of the disadvantages include that it's highly user-dependent, accessibility for scanning is required, and the penetration of deeper structures can be a challenge, and is limited, therefore, to assessment of the bony surface, and it gives poor global view of large areas of abnormality and unsuited for large areas of coverage as a result. And I thank you for attending.
Thank you for staying with us. The series of talks are over, and we are now open for questions. I think there was one question in the chat for Stephen regarding how to tell the plantaris muscle from the aponeurosis.
Yeah, it's a really good question. So thank you so much for asking it. The way that I differentiate the plantaris tendon from the free gastrocnemius aponeurosis is to start at the distal end of the Achilles tendon. So if I start distally and I'm working my way proximally up the Achilles tendon is really very oval shaped. And as you're heading more proximally, it's like if you're trying to make a noodle, you're starting with a round piece of material, and then you've got a rolling pin and you're flattening it out. So as you're heading proximally, that round structure, which is the Achilles tendon, is becoming thinner and thinner and thinner
and it's becoming broader and broader and broader. So as you come up towards the medial gastrocnemius, you're going to see quite a broad and still moderately thick structure. And just on the medial edge of it, and just underneath it, you'll see the plantaris tendon. So the plantaris tendon is very narrow and it sits just underneath the free gastrocnemius aponeurosis. So I feel like it's quite easy to navigate. If you start distally at the calcaneum and work proximally, head up, follow the medial side of the Achilles tendon up, and eventually you'll see the free gastrocnemius, which is just the proximal end of the Achilles tendon as a broad structure. Immediately underneath it on the medial lip, you'll see the plantaris tendon. So what I see all the time now is I hate to think how many times I've called these plantaris tears, because when I see a bit of hematoma in that area and then I see what is a fairly thin structure that's been popped in half, I now know that it's the free gastrocnemius aponeurosis, not the plantaris tendon. And when I look now, I can see the plantaris tendon underneath it, so sitting just deep to it, and that continues all the way up. And it's very, very uncommon for that to be affected. So I think plantaris tears in this area are actually quite rare.
Are there any other questions?
There is one other way that you can think about it, and that is if you start a bit higher up. So if you start looking through the medial gastrocnemius muscle, so above the free gastrocnemius aponeurosis, you're looking through that muscle and you can see the soleus muscle underneath it. And between those two muscles, you'll see there's just two white lines. And those two white lines are just the aponeurosis of the medial gastroc and the aponeurosis of soleus. And if you scan in the short axis, in between those two white lines, you'll see a little small echogenic little cylindrical shaped thing, and that's the plantaris tendon. If you look at it in the long axis, you'll see the two white lines. Then all of a sudden, instead of two white lines, you'll have like four white lines like this. And because the extra two white lines in the middle is the plantaris tendons that has appeared, and you can follow that down and you can show that that's in no way involved in the disruption that's happened to the free gastrocnemius aponeurosis. So you can attack it from the top, you can attack it from the bottom, but I think it's actually quite easy to differentiate what is the aponeurosis and what is the plantaris tendon.
I hope that answers your question. I have a question for Stephen. I don't know whether I was not paying much attention, but I know you did cover a little bit about the deltoid muscle on ultrasound, deltoid ligament on ultrasound. I'm just wondering, how good is ultrasound at evaluating the medial tendons, medial ligament?
Yeah, look, I think we're very good at it, and people get mystified by the deltoid ligament complex. Don't be confused by it. All it is the joint capsule of the ankle joint. That's it. So the deltoid ligament complex is just the medial joint capsule, and because the medial ankle is connected to the tibia proximally, so there's nothing else. The origin of it is always the tibia, but then the distal end is shared between a few structures. So if you're a bit more posterior, the joint capsule connects to the talus. If you're sort of in the middle, if you like, it attaches onto the calcaneum, more specifically the sustentaculum tali of the calcaneum. And if you're a little bit in front of that, the joint capsule attaches onto the spring ligament. And if you're a bit further in front of that, the medial joint capsule attaches onto the navicular. And so that's why we have different names for different parts of the deltoid ligament. So from posterior to anterior, we call it the tibiotalar, then the tibiocalcaneal, then the tibiospring, and then the tibionavicular. But they're not four separate structures. It's just one continuous sheet of collagen. But because the distal end has different bony and ligamentous attachments, we give it segmental names. But at the end of the day, with ultrasound, you can sweep around the whole width of it and you can just assess the medial joint capsule. It fails in only two ways. So I think it's quite easy to work out. The first way that it fails is where the posterior part, so the tibiotalar part, gets a compression injury. And that occurs because the medial border of the talus collides with the medial malleolus of the tibia and it crushes the joint capsule, and that causes a synovitis, which we know as a POMI lesion or posteromedial impingement. The other injury that occurs with inversion is more anteriorly, so more at the tibiocalcaneal or tibiospring component, and that's where the deltoid ligament gets degloved off of the tibia. So you get a stripping of the proximal end of the joint capsule from the tibia, and it's exquisitely tender for the patient, and you get a lot of regional edema in that area. So I feel like with ultrasound, I can walk around that deltoid ligament complex. There's a few little tricks with how you position the ankle, so posture of the foot's important. But if you learn the postural tips with the foot, you can see it all quite easily. And I really enjoy the medial ankle as far as looking at the joint capsule deltoid anatomy.
Thank you for that. That's a great talk, great series of talks, actually. I don't know whether there are any questions from the audience or from anyone else.
Please ask them. If there's anyone in the audience that has a question, please pop it in the question and answer chat. I'd love to talk to you. The other thing with the deltoid ligament, just while we're waiting for another question, is people think you have to have an eversion injury to damage the deltoid ligament. But all of these injuries I'm talking about are all with an inversion injury. So that when you roll your ankle in the standard way, you tear your anterior talofibular ligament, you may damage your calcaneofibular ligament as well. And as that happens, you then have a contra-coup injury where you're damaging your deltoid ligament at the same time. So it becomes part of my standard protocol for assessing an inversion injury. The moment I see an ATFL, anterior talofibular ligament injury, I'm really interested to see what's happened to the medial joint capsule of the ankle.
Actually, that's an interesting thought because I don't know whether you are thinking that the deltoid may be injured as part of a compression during an inversion injury. But actually, as a person who often has ankle instability on both sides, I find that sometimes when you invert your ankle, you actually then do an overcorrection and do an eversion after that. And that may actually, I think, be why you may injure both the medial and lateral ankle. Yeah.
Yeah, I agree entirely. So with instability, you get injuries on both sides, and you do tend to overcompensate and can overcorrect. That's very much like driving a car. When you make a mistake, you can overcompensate, I think. I can see another question there, and that is, how do you find the substentaculum tali? Let me give you some very clear advice, because this is quite simple. So what I do is I start transverse just above the medial malleolus. So I've got a transverse picture of tibialis posterior sitting right on the medial malleolus. So just your standard tibialis posterior short axis picture. And then what I do is I just follow the tibialis posterior in its short axis. Now what that means is I'm not bringing the transducer straight down towards the floor. I'm sweeping it around the malleolus like this, okay? So as you're sweeping it around the malleolus, the moment when you get to about, so it looks like it's sort of 5 o'clock on the clock there, when you get to about that location, the tibialis posterior leaves the bone of the medial malleolus. So it's now sitting on top of some soft tissue. And that soft tissue is the tibiotalar part of the deltoid. And the bone that you're seeing there underneath that soft tissue is the talus. Now, as you continue around, when you get your transducer exactly at 6 o'clock, so in other words, you've got the medial malleolus here and the probe is going straight down at 6 o'clock on the clock, another bone will appear, and it's further away from the medial malleolus, and that bone is the calcaneum, and that little bump that you're seeing in the bone there, that is the substentaculum tali. So if you drop a straight line down from the medial malleolus, a straight line down, and put the transducer in that plane, you'll be in exactly the right spot to see the substentaculum tali, and you'll see a thin band of collagen connecting that bony landmark back to the tibia. And then if you move around, so you've gone past 6 o'clock and now you're sort of coming around to 7 o'clock, you'll see that the substentaculum tali will disappear, and you'll actually be then looking at a short axis picture of the spring ligament. So that's the calcaneonavicular ligament, or the spring ligament as we know it, and you'll see the medial joint capsule attaching onto that. So for substentaculum tali, 6 o'clock, that's where you've got to be, and you'll see it every time. You can palpate it too with your thumb, you can feel it.
And one more question. Yeah.
Yeah, I can see that question about, do I assess the spring ligament together with a deltoid complex? So for me, if it's an inversion injury, I'm not too fussed about the spring ligament, because you don't damage the spring ligament with an inversion injury. So it depends on the clinical presentation. So if it's for an inversion injury, the answer is no, I'm not very interested. However, if the presentation for me is someone who has developed pes planus, so they've got an acquired flat foot, or I see that there is some tibialis posterior dysfunction or tibialis posterior pathology like a tenosynovitis or a longitudinal split tear, then I'm very interested in not only the deltoid ligament complex, because that helps to support the tibialis posterior and the longitudinal medial arch, but also, most importantly, the spring ligament. And then I would also have a look at the plantar fascia, because that's another static stabilizer of the longitudinal medial arch. So spring ligament for me comes into more of a longitudinal medial arch dysfunction problem, which is a spectrum of disease that involves the dynamic stabilizer, which is tibialis posterior, and then a group of static stabilizers, which include the deltoid ligament complex, the spring ligament, which is the supramedial portion of the calcaneonavicular ligament, and also the plantar fascia plays a role in it as well. So all of those things come together for me as part of a flat foot, acquired flat foot, or pes planus type examination.
Thank you for some very good questions. We have about time for just one more question.
I mentioned tonight at the end of the videos that if you put the letters ASA in for a coupon code, you get a nice discount for my website. But if you put the word Canon in, you'll get the discount just the same. So just put Canon in. That'll keep our lovely sponsors out front and centre. So thanks so much to Canon for supporting this event. If you put that in, you'll get a nice cheap discount for my website, and you can enjoy all the other material.
Okay, I think we're probably no more questions. We've come to the end of this session, and I really like to thank all the speakers, especially Stephen, who has to be up quite late at night to help answer questions for this webinar. And thank everyone for attending and supporting this session, and I hope you have found it useful.
Thanks so much, everybody. And thanks to Jeff and Canon and the Canon team for putting this event on. It's been wonderful.
Thank you. Thank you. Bye-bye. Bye.
Good night, everyone.
Good night.